All right, good afternoon, everybody. Welcome. Thank you very much for coming to 1776. ONC and the Idea Lab have put together a very nice program for you all tonight. My name is Damon Davis. I work at the Department of Health and Human Services in our Idea Lab, where we focus on innovation, design, entrepreneurship, and action. Part of that action is bringing programs like this to you today in conjunction with ONC. I want to thank Maya Upaluru, Simone Myrie, my colleague Alan Mouchet, and 1776 for hosting us tonight. There you are, Alan. So without further ado, I'm going to turn things over to Mark Greenberg. He is our acting Assistant Secretary for the Administration for Children and Families. Administration for Children and Families is sort of lovingly known as the services in Health and Human Services. So without further ado, Mark, I'd like to turn things over to you.
Thanks very much, Damon. Good afternoon, everybody. Thanks to the organizers of today's event. Thanks to all of you for being here for it. As Damon indicates, I'm Acting Assistant Secretary at the Administration for Children and Families, ACF. ACF is the part of HHS that is responsible for a wide range of programs at the federal level, principally ones that provide benefits and services for low-income children and families and communities. So within our jurisdiction, this includes, but is not limited to, domestic violence and child care and Head Start and child welfare and child support and temporary assistance for needy families, TANF, refugee assistance, runaway and homeless youth programming, programs addressing sex and labor trafficking, programs serving unaccompanied children, and more. So lots of programs. In many of these programs, there are goals to identify low-income, vulnerable populations, to connect them with appropriate assistance, to provide benefits and supports to strengthen families, and to promote economic mobility and financial security. So the reason I'm here today and have joined into the discussion is because we, along with many of our colleagues at HHS, think that there are significant opportunities to use new and emerging technologies to help to address these and related goals, and for startups and developers to be using government data to do so. In recent years, as you all appreciate, there have been extraordinary stories of innovations and technologies that are improving our lives in multiple ways and making us, we hope, healthier and safer. And there's been important progress in the use of health data, including the use of federal data that HHS has made available. But we think that there probably hasn't been the same degree of innovation and progress in a range of areas that relate to the needs of low-income people and low-income communities and the delivery of human services. Let me just give one example. If you envision a low-income parent in a wide range of communities across the country, if they lose their job, they're at risk of eviction and homelessness, they're struggling to get by, and they want to know who they can turn to for help. In many communities, there's not an easy way to get needed answers. There may be different kinds of help from different government and non-government agencies, but no single place to find it. If they connect with the providers often won't know what other providers do or what their eligibility rules are. Each eligibility process may be separate, and if they need to apply for multiple benefits and services, it may result in multiple applications with information needs that can be repetitive and duplicative. And in addition to that, there is no Amazon or Yelp or TripAdvisor or any other kind of website to bring together the shared wisdom of many others about the experiences of navigating the systems or the quality and the effectiveness of providers. So technology may not be able to address every issue here. There are policy issues, there's legal issues, there's other challenges, but there's also little doubt that technology could play a key role in making things better. So we hope that you and your colleagues will take on the very broad challenge of exploring how new technologies can do more to help low-income, families and communities connect to needed benefits and services, identify opportunities for advancement, and spur innovations in the quality of the services that are available to them. We think that federal data that's collected at ACF and at other federal agencies can contribute to that effort. For us, as part of the overall coordination work at HHS, we created an ACF-wide health data initiative team to evaluate our unpublished data sets. Since 2012, the team has published 85 publicly available data sets on healthdata.gov. So there you can find, in these data sets, technical assistance information, program performance data, federal monitoring data from a variety of sources. For many of the programs, it'll include characteristics of those who are served, such as refugees or children served in the child care program. And we've got some program service locations and contact information by location and type on healthdata.gov. Our Office of Head Start has already developed a web-based tool for finding Head Start program office contact information, which is searchable by location, grant number, or center type. But for other programs in our data sets, we may not have all the information that is needed. We may be able to tell you where the state agency is, but that really doesn't answer the question of, if I need help in this community, what do I do, where do I go? But having the state agency information can then link you to other data to potentially integrate things in a way that, that we haven't, but perhaps someone could. So we think that our data can be useful for a wide range of purposes. We're mindful at the same time there's limitations and gaps in what the federal government collects and what it can make available, but it is a valuable starting point. And we hope that this and related conversations can spur discussion and exploration of what might be possible. So again, we thank you all for your interest and greatly look forward to today's exchange. Thanks.
Thank you, Mark. So I think what you're hearing from Mark is an overarching desire to spur the innovation that a lot of you are so interested in terms of creating some interconnectivity between social services delivery and other parts of caring for individuals and populations. I think one of our big challenges is, in fact, trying to create that interconnectivity between medical and clinical and healthcare systems and the needs of social services populations as we all consider what it looks like to care for an individual as a holistic view of that person, not just inside the clinical setting. So as Mark was so gracious to mention, healthdata.gov is a huge resource for any one of you out there who is very interested in finding the data resources that may be the fuel for what it is that you're trying to accomplish when you are innovating in healthcare, social services, research, or what have you. So I would encourage you to go to healthdata.gov and try to locate the resources that you are interested in finding. And if for some reason you are not able to find those resources, I highly encourage you to reach out to us and let us know that there are data sets that you are interested in seeing. So without further ado, I'm going to invite the panelists for the next panel to come on up. I'm going to come on up. I'm going to invite Brian Sivak, our Chief Technology Officer for the Department of Health and Human Services, to come up and moderate this panel of our distinguished guests here. So without... Oh, I apologize. So it looks like you guys are going to do your talks. I'm sorry. So stay here, but you guys are going to come up here in the order of your presentations, and I need to know who's first. It would seem that Susan Jenkins is first. So without further ado, Susan Jenkins.
Thank you for having me here. I'm excited to talk a little bit about the data that the Administration for Community Living has. We are an operating division within Health and Human Services. And by way of an overview, ACL, the Administration for Community Living, started in 2012. Previously, we were the Administration on Aging, and then the Administration for Intellectual and Developmental Disabilities joined with us. And since we have had other agencies come into where we are. And so our mission overall for all of our agencies and subparts is to maximize the independence, well-being, and health of older adults people with disabilities across the lifespan, their families, and caregivers. And so our agency promotes strategies that enable people to live their lives in communities, live how they want, where they want, to be able to achieve the things that they want to achieve. And we're made up of a number of different program offices. One of them is the Administration on Aging, and it carries out the Older Americans Act of 1965 to promote the well-being specifically of older individuals by providing programs and services to help them live independently and in their homes. But there's also a segment that looks at adult protective services, exploitation, neglect, and financial abuse. And we recently, under AOA, obtained the Senior Health Insurance Programs, the SHIPs, from CMS, and we're piloting a national data system for adult protective services. Another big program office that we have is the Administration for Intellectual and Developmental Disabilities. And that provides financial and leadership support to organizations that exist specifically for people with developmental disabilities and their families to obtain the supports that they need and want to be able to live in communities. And very recently, I think as of 2 days ago, officially OMB has approved that the National Institute on Disability, Independent Living, and Rehabilitation Research has joined into as part of ACL. And NIDLR, as it's called, is to generate new knowledge and promote effective use to improve the abilities of people with disabilities to perform their choice, their activities of their choice in their communities, and expand society's ability to support those choices. As far as data, I will talk mainly about AOA and AIDD because NIDLR is so new with ACL. At this point, we're not entirely sure which data we will be making publicly available and how we will be making it available, so stay tuned for that. But as far as AOA, we have two main ways that you can get to our data. We do submit to data.gov, but separate from that, we do have the Aging Integrated Database, and that provides information about the AOA Title III, Title VII, and Title VI services, which are supportive services for older adults, for tribal communities, and for protection against abuse, neglect, and exploitation. And we also, in the AGED system, as we call it, have census data. We get a special tabulation of data because our population is primarily 60 plus, and a lot of the other populations are 65 plus. And so we have a special tabulation that includes that 60 to 64-year-old population. And using AGED, you can download information about our services and the census data as you want. We also are part of the Federal Interagency Forum on Aging-Related Statistics, which produces the Older Americans Key Indicators of Well-Being. Every 2 years it was, and now it's moved to every 4 years, and that's available through agingstats.gov. And there are 36 indicators of the lives of older Americans and their families, including population information, economics, health status, health risks, and behaviors. And the data are available in tabular format. There's a book that comes with it, but all of the data are also downloadable in Excel format through agingstats.gov. And there's a lot of information also available through the Administration for Intellectual and Developmental Disabilities. The National Core Indicators Project is a project that has standard measures that are used across the participating states to assess the outcomes of services that are provided to individuals and families. And there's a section for older individuals and individuals with disabilities, and a separate section for individuals with developmental disabilities. And there's information on key areas of concern, including employment, rights, service planning, community inclusion, choice, health, and safety. And so on that website, you can download and look at that information. There's also the State of the State that's administered by the University of Colorado to investigate determinants of public spending for intellectual and developmental disability services in the United States. And they have longitudinal information about revenue, spending, and programmatic trends at the state and national levels. The Access to Integrated Employment is a project conducted by the University of Massachusetts, and it's been in place since 1988. And the statedata.info is a website that illustrates service system investment in day and employment services. And realstories.org has more qualitative information featuring stories of youth with intellectual and developmental disabilities that are in paid jobs in their communities. And last but not least, the National Residential Information System Project, RISP, is conducted by the University of Minnesota, and it presents annual state-by-state information and national statistics on residential services for people with developmental disabilities, and it includes state and non-state institutional settings and community and home-based residential services. And I can say on behalf of ACL, we are very interested in having people use our data that's available, but also we try very hard to work with organizations and networks of providers and governments to link people to the services that they need in the most easy, accessible way. And so having systems that link that information so that if an individual comes for a service, contacts any of the agencies or service providers, behind the scenes, all of that information is connected so that that service provider knows what other providers provide services that that individual may need, knows what that individual may have already received, and be able to provide seamless service. That's really what our goal is. And so I thank you for your attention.
Thank you so much, Susan. Next up, we're going to have Jennifer King of the Administration for Children and Families. She is one of our health data leads at the Department of Health and Human Services. We have individuals across the department with whom our office interacts with to try to get data to be publicly available from any one of our various operating divisions. ACF has been a stellar participant in terms of getting data out for more use. So I want to introduce Jennifer King to you now.
Thanks, Damon. I am also with the Administration for Children and Families, and Mark Greenberg is my boss. Also, another one of my bosses is here as well. My role at ACF as an analyst, I focus on using statistical data to see the trends of program performance. And then we use that information to make strategies on how to better serve our populations, which, as you might guess, are children and families. As Damon mentioned, I also have another role as the ACF Health Data Initiative Lead, and that's actually a really great job because we have been able to evaluate all the data sets that we currently have in ACF and see what is available to publish. And we are a subset of data.gov. I know some in our group use data.gov for your information, and we are a subset. But you can get to our ACF information at data.gov or healthdata.gov. So, since Mr. Greenberg spoke about ACF specifically, I'm going to talk about federal data in general. Okay. We feds have been really great at collecting and reporting data. We're good at that. The thing we haven't been so good at is making that data readily accessible to the public. Public data being available to the public. Okay, so that was something we thought, hey, we need to work on this. Fast forward to 2013. Now, this is a terrific step towards open data. President Obama signed Executive Order 13642 on May 9th in 2013. And what that means is that now machine-readable open data is the standard for government. And that's terrific because we need a standard to make it usable to everyone, not just us, but to everyone. Are we there yet? No, we're not all the way there, but let me tell you what has happened. So far, thousands of government data resources across fields such as health and medicine, energy, public safety, education, and of course, health and medicine have put data sets up on data.gov or healthdata.gov. So I think we're really making a lot of progress. Now, so we're good at collecting it, and we're getting better at sharing it, but what are we going to do in the future? Well, this is where all of you come in. We need to take that data, and we need to make it useful. We need to make it alive. And what we need to do to achieve better health outcomes is to take this data and do a couple of different things. Since we've moved on from the report and file methodology, now it's a data life cycle. So part of that life cycle that still needs to happen is taking that data and moving it to people who can use it. And we hope that you all have some help for the government on this, on ways that people can use it, or something that we can use between interagency data. For example, I work for ACF, but I need to use Census Bureau data quite often for poverty rates, homelessness, characteristics of our population. So we would love interagency tools for ourselves as well. So I'm really thrilled to be a part of this event and have the opportunity to get the creative ideas from you all. And thanks, and we'll look forward to talking more about this in the discussion part.
Thank you, Jennifer. One of the things that I think you heard from Jennifer is both the need to share data from our own coffers out to you all as public innovators, but also the need to share data across our own lines within the department and across agencies, which is a creative point that I hadn't really thought about mentioning here. So thank you very much, Jennifer. I am unclear as to who is up next, but it would appear very good. Then I will allow you to introduce yourself.
Hi, I'm Adam Kramer, and I'm with the National Park Service's Office of Public Health. And I must have just hit the wrong button altogether. Nothing like, you gotta love technology. When it works, it's great. When it doesn't, you run with it. So I'm with the National Park Service's Office of Public Health. And, one of the questions may go, well, what's the National Park Service doing here? And really, one of the things to keep in mind is we're a land management and conservation agency, so why would we be here for help? Well, you got to realize we have 405 national park units. We see 277 million visitors a year. And with this, we're going to show a little bit of how some of our data can be brought into it. And thinking, when you're looking at data, to think broader, not just with what HHS brings, but with what some of the other federal agencies bring. Jennifer mentioned the Census Bureau. They bring a lot of data. It's commonly used. But we do have a lot of other data sets that may be out there. So within the Park Service, we have an Office of Public Health. And with that, we basically serve as the internal health department for the Park Service. So we do a lot of environmental health, assessing food safety at restaurants, looking at water, wastewater systems. But we also have a health promotion branch. And that's what we're going to talk a little bit about here. So with it, I do want to talk about what are some of the data sets that are there. Data.gov got mentioned. For the Park Service, we have over 1,400 data sets that are on data.gov, primarily boundary maps. We also do have vegetation data, hydrographic records, as well as even getting into Civil War records. We do have water quality, which gets shared with EPA Store-It database. And then one of the internal ones we have is the NPS, the IRMA data portal. It's an integrated resource management application. And there we have information such as visitor use statistics, park species lists, if you're ever wondering what animal is there, water quality data, as well as some biological monitoring protocols. And one of the other ones is recreation.gov, which will give you access to information on activities that are available through publicly funded lands across the country. And with it, one of the applications that really got developed with our data is the DC Park Prescription Program. And what they did is they took a lot of our boundary files and then they did assessments of the individual park boundaries and what were the parks, what were the facilities that were there, safety, everything else. And working with one of the local medical providers here, they actually integrated it into their electronic health record system. So now when they have people coming in, they're looking at prescribing nature, giving their patients this information on Where can they go? Where can they go to take a walk? What are the activities that are there so people can get out, get a little bit of exercise? Is they found about 1 in 3 chronic diseases are going to be driven by lifestyle. So if we can adjust that lifestyle, getting people exercising outside, we have that ability to affect those chronic diseases. So with their short-term, they're looking to do this. Long-term, they're looking to see what is the effect of prescribing nature. Is that really having an effect on people's health? I think logically we go, well, yeah, if people are exercising, it is going to be good. But again, this was done as a combination of those data layers that we had, but with a little bit of exercise. So it's one of those where we can combine our data with other sources to find something. So again, I would, recommend as you're thinking about this, what are some other data layers that are there that may be non-traditional health agencies to think about? And we just kind of have a little bit of our contact information up here, but I look forward to answering any other questions as we move into the Q&A section.
Thanks a lot, Adam. And I think what you said at the end there was very important. Thinking about alternative layers to the data that can be meaningfully used to create some of the innovations that you guys are so interested in. So don't necessarily just think about healthcare data. Don't think about necessarily just medical data. The environmental data and other kinds of sources are going to be incredibly valuable for each and every one of you. Without further ado, I'm going to turn things over to the Health Resources and Services Administration. My man Paul is also a health data lead at HHS and has been very instrumental in getting HRSA data to be made available on healthdata.gov for all kinds of cool and creative innovations. So without further ado, over to Paul.
Good afternoon. So, as Damon said, my name is Paul Monsager. I work at HRSA. My office is the lead contact for open data activities, but I think we share a lot of similarities to ACF. You'll see we are a service agency. Our mission is to improve health and achieve health equity through access to quality services, skilled health workforce, and innovative programs. We provide services to people who are geographically isolated, economically or medically underserved through a wide range of programs covering a wide range of people and across the country. I've listed some of our larger programs, but it's programs for HIV and AIDS care, women, children, and families, people receiving primary care services, along with health workforce training programs, health workforce distribution programs, and all sorts of other programs here. But we're primarily a grant agency. And as such, here's a few examples of our big grant programs and the data we have. So we have data about our grants and our grantees, about who they serve, where they serve, performance metrics, such as the health center data, which is reported in the uniform data system. The Ryan White HIV program also releases data about patients at the state level, and then the Maternal and Child Health Grant Program also releases data about their performance metrics and their clients they've served. More data is available as well. We also collect data related to the populations we serve. So we have a very big, rich data source called the Area Health Resource File that has a lot of data about the nation's health workforce. So this is providers, this is hospitals, this is healthcare facilities. It's all at the county level. It's integrated with census data, it's integrated with other service information, and we've a whole lot of different ways you can get access to it. You can download it, you can look at it as a mapping tool, you can compare counties. We also field national surveys to learn more about the populations that need our services. So the Maternal and Child Health Bureau fields national surveys of children and national surveys of children with special needs. These are also downloadable. Depending on what you need, there are different levels of data use agreements there. We've also surveyed nurse practitioners to look at their histories and their needs as clinicians. So more is always also available on our websites. So I'm sure we'll get to that when we talk about it.
Thanks a lot, Paul. Cord is dangerous. Without further ado, I'm going to turn things over to Manat, who is with Healthify. So I'm going to let you explain Healthify.
Awesome. Well, thank you so much.
No problem.
Hey everyone, thank you again for inviting me. It's an honor to share the space with so many incredible speakers, and the space itself is pretty incredible. This is probably the most interesting podium I've ever used. So my name's Monik. I'm the CEO and one of the co-founders at Healthify. And at Healthify, what we're really trying to do is build solutions and the infrastructure necessary to address social determinants. And before I get into the nitty-gritty of what we really do on the ground, I want to talk a little bit about where we came from and how we got started and why we got started. So we got our start working in East Baltimore in a community that has a lot of need. We were working at a pediatric clinic, and I see a fellow volunteer here that I was working with for 3 or 4 years, working at a community psychiatry clinic and actually doing community health outreach for a men and family center for about 4 years. And I think I'm preaching to the choir when I say that what we saw day in and day out was, at the end of the day, a majority of an individual's needs were linked to social needs. Food insecurity, housing, childcare, access to mental health services, GED programs, access to transportation. We saw these issues every single day, but we had no good way to actually address it. And some of the major pain points we identified were, first, screening. You know, understanding if a family is food insecure right now from the healthcare's perspective happens about 12% of the time. So think about that. In a population where food insecurity is very prevalent, we have no understanding of what is the severity of the need in a family, and it's not really stored in any health record system either. Even though we know that if a family is food insecure, they're 40% more likely to be hospitalized and much more likely to have poor health outcomes down the road. So that's one major pain point. We have no good barometer of knowing what are the needs that are actually there. Second major pain point, which was alluded to earlier, is that there are some incredible services and organizations on the ground, in the trenches, doing great work, thousands of them, and of course benefit programs. But figuring out what services are open, what services are actually working well, what the information is to share, was very tough to do. The information is mostly paper-based, not validated, nearly impossible to share with individuals who need help, or impossible to share with staff members who need the information as well. And none of it is tracked. So even if we were lucky enough to know that someone had a need, figuring out the service that could best help them was impossible. And then the final pain point we identified was follow-up. So we had an expanding caseload, and of course with Medicaid expansion, caseloads in the healthcare space keep increasing. And imagine trying to call 60 families, understand their needs, figure out if the referrals are working, if they went, if they need support, along with actually managing the chronic illness they might have, compounding on all these problems, and you get a good picture that this was basically an untenable situation, that follow-up could not happen and really did not happen. And that's really the context of why we got started. We said there's got to be a better way to a lot of this and coordinate around social services. I don't think, as we'll probably get in the Q&A, I don't think there's a perfect solution to a lot of these needs. But we kind of looked at it that we don't want perfect to be the enemy of good. And if we're serious about healthcare, and I have a slide here, you know, 1/5 of healthcare spending linked to social needs, 60% of health outcomes. If we're really serious about value and improving the health communities, we need to be really methodical about how we understand social determinants and their relation to health. So what do we do? So we do a few things. One of the first things we do, and we share this with other people on the stage, is we get a good understanding of what services are available. And we pull out from a lot of local, state, and government data sets. For example, Department of Veterans Affairs has great data sets on homeless services for veterans, or caregiver support services for veterans and veteran areas to get help generally. Or SAMHSA has great data sets available for looking at what are mental health and behavioral health services in certain communities. We pull all this information, we standardize it, we validate it, and categorize things to make sure they're readable, 4th to 6th grade reading level for descriptions. We make sure that the intake requirements are categorized appropriately. We explain who the service is really for and double-check hours of operation. And that's really the first step. When we put this in an interface, kind of like earlier someone alluded to a Yelp of services, very similar. People can rate, edit, comment, share, and look at these services in a more effective manner and trust that this information is accurate. And then we actually have a screening system that understands needs and matches people to services. And this is primarily built from research coming out of Boston Children's Hospital, where we ask questions about an individual's social needs and then automatically connect them to a service. So if there's a single mother with a child under the age of 5 who has self-identified through the patient-generated data that they might need help with the crib but can't afford it, we will direct them and provide them transit directions to actually find access to a community center that's helping with infant child supplies and automatically determine the eligibility for WIC and the next steps for applying. So that saves quite a bit of time. And really the value of this is we then give all this information back, and one can actually see in a population who is most at risk, what are the needs that are actually popping up, what is the service gap between needs and what services are available, and then we go ahead and automate follow-up as well. So we text individuals primarily right now about how things are going, if they need more help, and actually ask them to rate services as well, so we finally get the other side of the equation of what do people who are accessing these services think about them, and are they actually benefiting, and what are their thoughts on it? And I think that's hugely valuable. And we're actually working on what we've always wanted to do, which is full coordination of these needs, where the agency in question is on the same platform and the referral is sent to them and they understand what's going on. And we're doing this with a PCORI-funded trial out in Baltimore. And that's really the end goal is if you have a full coordinated system with patient-generated data, with interventions, with engagement, how does it affect outcomes and how does it affect claims data down the road? And we're trying to build the systems in place to make that happen. And so where are we right now? So I'm proud to say we made a lot of progress in the past almost 2 years now, a little over 2 years. We're live in 8 states. We have over 1,000 healthcare staff using the platform daily, and these are community health workers out in the field. These are nurses. These are case managers, behavioral health specialists, and we have hundreds of other community-based organizations using the platform as well. We have 3 ongoing research studies with PCORI and AHRQ that are really looking at this holy grail of if we really look at social determinants and coordinate around a referral, what is the impact to make sure it scales in a managed care setting or otherwise? And we have some great people we're working with. Johns Hopkins Healthcare, where we're from, is a client, Banner Health, Philips Healthcare. And I can't name any names, but we're also working with one of the largest health insurers in the United States, too. Thanks so much.
One of the things that's always so interesting to me is to hear the stories of how folks like Monik and Shelley from Purple Binder are actually using the data. It's very inspiring to see what their vision is and how the federal data can make that a reality. And that then starts to speak to how it is that Medicaid or other parts of CMS, HRSA and others can start to envision how it is that they're going to make their data available in order to be part of that inspired vision for how we can create a more connected, interoperable continuum of healthcare and social service delivery. Without further ado then, I'm going to turn things over to Shelley, whom I'm hoping will tell the story of why Purple Binder has the name that it does. So without further ado, for Shelley.
The suspense, right? Thank you. Hi, everybody. My name is Shelley Milosevic Johnson. I'm the Director of Client Services for Purple Binder. And I'm going to start off like we kind of started the whole evening off, where I'm going to ask you to imagine with me, if you will, a homeless mother with 2 children who's just left her home because of a domestic dispute with her husband. Or a veteran who's new to a city because he was recently promised a job, and once he arrives in that city, there's no job ready for him. So I ask you, where do these people turn when they have no money and have no support network in these places where they find themselves? And how do they or I, as a social worker, know where I should be sending them? I don't know what all of the community resources are either. And so for those of you who have ever done case management, I'm not sure, I sure have, it's funny because we social workers and case managers carry around paper binders, literally, with handwritten notes and outdated information and coffee stains. And so that's the reason why Purple Binder is named Purple Binder. Our co-founders saw a very, very messy Purple Binder and decided that that was the one thing that they wanted to replace with our product. And so that's how we got our name. So under the ACA, we have a mandate actually that we need to be considering how people are staying healthy outside the 4 walls of our community health centers and hospitals. We need to keep people healthy in the communities where they live, work, and play. And today health systems are doing that by referring or redirecting patients into more appropriate forms of care, as well as decreasing the costs of those services. And they're doing that by building partnerships with community-based organizations. Some of the groups that we're working with to do this are health systems that do managed care and local governments. And we're helping them to leverage the community resources in their local communities, like primary health care, shelters, food pantries, and wellness centers. Our app keeps people healthy by informing them about what is actually available in the communities there, who's eligible for those services, and how they can access them. And it tells us, it helps case managers actually make quicker referrals, and more informed referrals, in fact, because they know exactly when things are opened, if people are eligible for them, that sort of thing. Some of the recent data that we've been using is from HRSA. Thank you very much. We've been using some of their FQHC information. From CMS, we're using their nursing home data and DME, as well as from ACF, your refugee health. Thank you very much. So what we do is we're sourcing this information not only from these great resources, but also from our clients. And we're bringing it all together, and then we actually augment that through a community research process. Our research team is made up of social workers, all having case management experience. And they're contacting each and every one of these organizations to verify the information is correct, as well as to get that nitty-gritty detail that's not always available to us online, or even by making one phone call to an agency. And so through this augmentation, we're creating new data. And so we're not just consuming it, but we're making it public and available to other people as well. And so one example of this is a partnership that we have in Southern California with the Desert Healthcare District. And they're partnering with the Clinton Foundation. And through this, we are creating a data set specific to them, but all that curated data is then released back out into the community in an open referral format. And we believe we're adding value to not only our clients by doing that, but also to any individuals, researchers, and nonprofit organizations that would want to use the data as well. Thank you.
So that's really exciting to hear that you're actually looking to contribute data back, because that's also a big part of the process. Don't just ingest the data, but actually take time to think about what the greater good is that you can be contributory to. So I appreciate you bringing up that last note. After Dr. Stephen Shaw from Medicaid presents, we're going to let Brian Sivak take over and do moderation of the panel. So over to you, Doctor.
Thanks so much. My name is Steve Shaw. I'm the Chief Medical Officer for the Center on Medicaid and CHIP. Great to be here with you, and just fantastic panel. I love hearing these stories about how we're using data. I think for myself, it's this issue of how do we think about, and I think the theme of the day is right, how do we think about innovating for the underserved? How do we think about linking those services? And I think those last two speakers in particular hit upon this theme. It reminds me of, I'm still a primary care doc. I see patients in a homeless shelter. A few years ago, I saw a patient, GSW, gunshot wound, in wheelchair bound, was discharged from the hospital because he had a clot in his lungs. So it's a guy who really needs his anticoagulants. He had seen, I think, 3 or maybe even 4 case managers in the last 2 days, and nobody actually making sure he got the meds that he needed to make sure the clot doesn't get worse in his lungs, right? So I tell this story because it's 2 things. Number one, we have a whole lot of state and federal resources paying for case management, and we're not getting our value out of it, right? And so when we think about what our challenge is within the Medicaid space, when we think about what we're trying to do under Medicaid, it's not just about how do we think about, and my job is primarily to think about delivery reform and payment reform for Medicaid. And it's not just how do we think about linking the hospital and the clinic and the home health agency, which I think we've gotten a lot of. We've gotten pretty good at this in the last few years, and this has been generation 1. And I think one of your slides, I think I have a slide just like it, talking about we can't just think about the linkages between our health agencies. It's got to involve how we're thinking about housing, about correctional facilities, about food. And so when we think about how do we link all these together, it comes back to a data solution. So here I am at an open data event, and the first thing I just want to get out of the way is that we don't have data particularly, right? So let's get that awkwardness out of the way first up top. But I want to talk to you about this because I want to sketch out a vision for what the future might look like and where we'd like to go. Medicaid, as many of you know, we are 68 million now, over nearing $500 billion in spending across the country, and growing with each year with more and more states taking up on our option to expand. And so thinking about what this means in terms of that vast population, and in particular, the theme of how do we serve this population better by linking services is critical to us. skipped a slide here. All right, so let me just start real quick with in terms of thinking about what is the first piece is really thinking about what we're trying to do under delivery reform. And the Secretary has outlined a vision for the department in terms of how we're thinking about value-based purchasing and innovating. And she points to three pieces in particular. She talks about our need to have better incentives. And so we need to give better incentives for care. How we paying for care matters. And I think we actually are starting to do that, right? And I think a lot of our state partners are starting to do that. We are changing the way we pay for care. But these other two pieces that she talked about, I think, are really mission critical right now. The second piece is we need to change the way we're delivering care. It's not just enough to change where the cheese is the maze and expect people to find it. We need to figure out what does that new pathway look like under Medicaid, and what does that care delivery system look like under Medicaid. And the third thing she talks about is the need to support data and quality information. How do we have that information, that view that helps all of us have an understanding of whether we're achieving our goals here? So, okay. So just one quick snapshot in terms of how Medicaid is using data today. And I think that this is partly trying to get at a sense of what we're trying to do about our data right now. And this isn't CMS for the most part, but I want to give a snapshot of what we're hearing around the country in terms of what people are doing, people like particular the last two speakers. So first, we're trying to think about how do we deliver better care? How do we think about providing better care? So I think you heard a little bit about, I think what we're calling colloquially is this idea of the integrators. How do we think about those services like those last two speakers that are really trying to connect the services for our beneficiaries? But it's also about how do we think about identifying service delivery. So I think about Washington State, and what they've done in the ER is to connect some of the social services databases in the ER in real time, in particular some of the prescription drug uses and correctional systems data databases, so that the ER docs have a sense of what that patient actually needs. And so they know that, for instance, if this is their sixth visit to the ER looking for pain meds, right? And so you think about that data system and the ability to deliver better care for our beneficiaries. It's fueled by that technology. I think many of you have heard of things like Text for Baby. People have heard about that. So the kind of ways, a lot of our beneficiaries don't have internet at home. Most of them have a smartphone. So trying to leverage that capacity in terms of thinking about that as well. The second is helping us understand what's going on with our beneficiaries. And again, I think about that Washington State example where they've integrated the correctional systems data and created a better predictive algorithm for identifying next year's high utilizers, identifying who's going to need our services before they're actually using them, and identifying the needs of these beneficiaries, identifying what they need in real time in terms of what we're trying to do for that. And then finally, how we're trying to pay for better for value in terms of thinking about how do we leverage these claims data systems to generate quality metrics and all that. So the future Medicaid data, I'll just leave it on that first bullet because I know I'm running on time and I think I'm the only one running over here. I was amazed. A panel of federal speakers, everyone keeping to their 5 minutes. It's remarkable. So I want to try and hold to that as well. But the only one I wanted to flash is that first bullet, which is called the Transform Medicaid Statistical Information Services. And I highlight this one because, as I said at the top, we don't have data. We will soon. So under this system that is mandated by the ACA for all of our Medicaid beneficiary, our Medicaid programs to be providing unified data to the feds in terms of under this new system, we are about to enter into a new era for the Medicaid program, which is actually having an understanding of what happens in our program. My first day on the job as Chief Medical Officer, first thing I did was I asked for a run of top 10 diagnoses by frequency and expenditures, and essentially the short answer was, yeah, I couldn't get that. We have proxies for it, and I've sort of struggled and gotten the intel we need, but it was a remarkable answer for me day one into the program. We will get there with the Medicaid Statistical Information Services, and so I want you all to be thinking about, as we think about how do we translate that in the kinds of uses that we're using now, and as we think about creating public use data files out of that, what do you all need from us? What do you all need from that data set to look like in terms of functionalities, in terms of what we need to do to help us on our mission altogether? Let me just stop there, and thank you so much.
Thank you, Dr. Cha. I'm often asked about whether we have access to Medicaid data, so it's exciting to hear that you have a future initiative. I can always tell them you don't. What I've never been able to tell them is that you will. So this is really exciting to hear. Quick change of program. Unfortunately, I didn't know this before I said it, but we have one more featured speaker here today. Liz Polena Hall is with the Office of the National Coordinator for Health IT, and they have a standards and interoperability initiative directed at social services. So Liz, please come on up.
So I just want to take a few moments to describe this really exciting initiative. As Damon mentioned, I'm Liz Polina Hall. I'm the long-term post-acute care coordinator at ONC. And the Office of the National Coordinator and CMS have partnered to launch a new standards initiative through the Standards and Interoperability Framework called the Electronic Long-Term Services and Supports Initiative. And so this initiative is focused on interconnectivity or interoperability. And it addresses one of the key care coordination challenges that that exist today, and that is sharing both social service and health information in the community. So today, this information exists in silos. There are different workflows and different priorities and a bevy of providers that support a person's health. So this ELTSS initiative will focus on identifying standards for key assessment and information domains, which could include both health and social service information to inform the creation of a longitudinal person-centered ELTSS plan that could be used by both health and community-based social service providers, payers, and individuals. Just to provide some background in case you're not familiar with SNI, the SNI framework is an open, collaborative community of stakeholders from both public and private sectors that includes providers, vendors, innovators, payers, researchers, state and federal government. Each SNI initiative is focused on a critical interoperability challenge and does through a well-defined process, which includes development of use cases and real-world piloting of the standards. Today, the community is focused on their use case development and focused on priorities for exchanging information to include keeping individuals independent at home, capturing a person's goals and preferences, and checking to see if that plan matches the person's stated goals and preferences. So one participant today called this My Life, My Way. So for example, this could include an individual identifying a daily walk, maybe in a park. But that person might have mobility challenges or trouble remembering. And so, one of the questions could be, does the plan identified by the individual meet the stated goals to keep that person to meet the goal and keep them safe? So we are very interested in bringing awareness to this initiative to the innovation community, particularly as we believe that mobile solutions will play an important role. The initiative meets every Thursday from 12:30 to 1:30 Eastern. You all, I think, have a one-pager to address this. I will call out my colleague Evelyn Gallego, who is the ELTSS Initiative Coordinator, and either one of us would be happy to answer any questions during the discussion.
Great. Thank you so much, Liz, for bringing that information to us. Let me just ask quickly. I know SNI Framework is on the ONC's website or something. Do you have a website that you would like to plug?
It's on the one-pager.
It's on the one-pager. You heard it there, okay? So we're going to take a couple of minute break. I'm going to tell you it's a 3-minute break because I know y'all will be late. So I will call you back in a couple of minutes. But please take a break, mingle, get to know each other. We'll reconvene in about 5 minutes.